So here you can see that the PR is fixed and it's prolonged. So that means actually it's more than one large in the block. That means actually it's reaching almost 0.26, 0.28. That means actually there is a first degree heart block. So here the ECG is looks normal, but there is apparently when you first degree is, AV block is very easy to miss, because especially when there is a bradycardia, you have this ECG looks normal, but you have to carefully look whether the PR is prolonged. So that is a first degree AV block. Now this is what is called the second degree type 1 AV block, or otherwise we call it as a Wenckebach phenomenon. So as I told, there is a gradual prolongation of the PR interval. So you can see that here the PR interval is just at the upper limit. Then you have the PR interval is prolonged. Then on the third complex, the PR interval is much more prolonged. And the fourth complex, only the P wave is seen, QRS. It's not followed by a QRS. Then you again see a P wave. Okay. So this is the Wenckebach phenomenon. Okay, so this is so you will get the P waves and QRS complexes, and you will get a kind of a gap. So when you see such kind of a gap in between the ECG, you should always look at the preceding PR intervals. If there is a gradual prolongation of the preceding PR intervals, we call it as a type 1 second degree AV block. So this is the type 2 second degree AV block. Type 2 second degree AV block, there is no prolongation, but there is a drop in QRS complex. So you can see that the P wave here is fixed, the PR interval is fixed, there is no prolongation, but every second P wave is not followed by a QRS complex. So that means actually there is the heart rate is only half of what is the normal heart rate, because every second QRS complex is not inscribed and it's missed. So you will get the pulse rate almost half of the normal heart rate. Now this rhythm is the third degree or complete heart block. You can see that there are many P waves in the ECG. But the QRS complex is only 3 QRS complex. That means there is no relation between the P waves and the QRS complex. So there is a complete dissociation. The P wave is produced from the SA node. The QRS complexes may be produced from the junction, that's bundle of T's, or it may be a ventricular rhythm. So both are produced from different pacemakers. So that's what we call the third degree heart block or a complete atrioventricular block. So that simply means there is on the ECG, there is no relation between P wave and the QRS complex. So you can see that the PR interval is somewhere the PR interval is prolonged, somewhere it's very close. There is no relationship between PR and the QRS complex. So that was about the AV block. Now we are looking at this. So we were discussing the rhythm. Okay. Now we are looking at the axis. So axis is always something very confusing for many of the people. But you need not, again, as a practitioner, not necessarily you should dig into the electrophysiology of the axis generation, but rather you should be able to say the axis of an ECG in a simple terms. Okay, so you should all know that the normal axis of the ECG stays between -30 and +90. So that is the normal axis of an patient of an ECG. So the axis determination takes importance because the axis, it's important in congenital heart disease, in pediatric heart disease. There are sometimes actually, the axis simply says the diagnosis. So, but in the ischemic heart disease, in the adult heart disease, the axis is sometimes not very clinically very significant. And we have many other investigative modalities now to look at the heart and the topographical position of the heart. So the simple way to learn axis is, okay, when you have an ECG, take the ECG and just focus on 3 leads, okay, the limb lead 1, 2, and AVF. Or you can just look at 1 and AVF. But I would say you look at 1, 2, and AVF. Okay. So if all the the leads I told is a positive deflection. That means actually you have positive deflection in 1, 2 and AVF, or in more simple way 1 and AVF, you have your axis is the normal axis. Okay. Now if the lead 1 is positive and lead AVF is negative, then you have the AVF or lead 2 is negative, you have the left axis deviation. So just previously we used to have that strip ECG, the long strip ECG. So they used to say you hold with one hand on the lead 1 and the other finger on the lead AVF, and just look at. So the 1 is positive and AVF is negative. That means actually it's a left axis deviation because you are holding on the left hand. Okay, it's a left axis deviation. Now, if the AVF is positive and the 1 is negative, that means you have the right axis deviation. Okay, then both are negative, you have the indeterminate axis, or it stays between the 90 to 180, minus 90 to minus 180. That means it's a no man's land indeterminate axis. So if both are positive, it's normal axis. The left hand one, the left is positive and the right one is negative. That means lead 1 is positive and the lead AVF is negative. That means it's the left axis deviation. The lead AVF is positive and lead 1 is negative, is the right axis deviation. And both are negative, that means it's a indeterminate axis. So this is as simple as that. So I think actually, I mean, for all clinical purpose, this is all what is required regarding the axis. So you can see that this ECG is very well a normal axis, 1, 2 and AVF is negative. I mean positive, it's a normal axis.